So I just wanted to welcome everyone, welcome to our panelists, and welcome to our audience. Thanks so much for joining us tonight in Eastern Time Zone. My name is Allie McLeod. I'm the head of branded programming at Women as One. I'm really happy to be here with you tonight to launch part 3 of the Women as One Leadership Academy with a virtual screening of Next Generation Considerations. The video is a third in a series of 4 that feature interviews from global women leaders on key leadership topics. In addition to today's event, I hope you'll join us for the screening of our final video, Industry Relationships, What's Important, which will take place on Monday, November 23rd at 6 p.m. Eastern. And just a quick reminder that all of the screening events are being recorded and will be archived and available on the Women as One talent directory. So if you missed one of them or if you want to go back and rewatch it, it's all available there. Tonight's event will feature a screening of the video, followed by a moderated panel discussion and audience Q&A. And a note to our audience to please use the Q&A button at the bottom of your Zoom screen to type in your questions. And our moderator, Amit, will go ahead and go through those and try to answer everyone's questions. Before sharing the video, I just wanted to introduce our participants in today's event. And thank you once again, all of you, for being here. Our moderator is Dr. Amit Goyal, co-founder of Cardio Nerds podcast and a cardiology fellow at the Cleveland Clinic. And then our panelists, Dr. Sonia Burgess, who is a consultant cardiologist at Nepean Hospital, Southwest Cardiology, and Sydney Southwest Hospital. Dr. Bob Harrington, the Arthur Bloomfield Professor of Medicine and Chairman of the Department of Medicine at Stanford University. And Dr. Tracy Wang, Professor of Medicine with tenure in cardiology at Duke University. Thanks again to everyone for being here. And now, without further ado, I'm very excited to share with everyone the video of Next Generation Considerations.
Right now, we're so connected. We have access to people in a way we didn't have access to people, and I think that's only going to increase. It's going to be more manageable to reach more people, and I think that's exciting.
COVID-19 has made us question, why do we need this? Why do we need the in-person visits? Why do we need the monitoring? Why do we need, there's so many things that we could question. And that honestly, technology could probably help us do much more efficiently and cost effectively.
We are starting to really leverage the data sources at our fingertips. So electronic health records, wearables, all the data collection mechanisms, even social media. But we're just scratching the surface there.
I think there's going to be a lot more machine learning and artificial intelligence in the field of cardiology. I mean, we can see it already happening with electrocardiograms. It's going to impact the way we do trials. We're going to use machine learning to try to select patients better, to try to, reach that final goal of individualized medicine or precision medicine. I do think it's heading that way. It's not just talk.
I've got patients, and these are not just young, healthy patients. I've got, some of my patients that I've been seeing for 10, 15 years, displaying their Apple Watch to me and their AFib algorithms to me. I really appreciate the data. We need to be able to figure out how do we actually effectively use those data. As practicing clinicians and as well as researchers, we really need to be able to keep our fingers on the pulse and be able to evolve quickly with it.
Technology is incredible, and if we don't embrace it and we don't see it as positive, we'll be dinosaurs that are left behind. And I think we just have to be careful.
Social media, oh my goodness, what an incredible tool.
The older generation weren't on Twitter and Facebook and what have you, but there's some really fantastic education and sharing going on place on these platforms, and that's connecting the younger generations throughout the world on subjects that are extremely important and allowing learning in places that are remote. So it's absolutely fantastic what it can bring to education.
It's always that a strength is a weakness, or there's danger in an opportunity. And therefore, I'm going to go with social media being the huge opportunity is also, I think, the challenge. We're living in an incredibly distracted generation. I worry for my own children, because the ability to focus, not to just flit from one thing to another and to keep being interrupted, that ability to focus is so critical. There was a period where I realized that I was getting all my work done only on the airplanes, on long flights, with Twitter, with Facebook, with all kinds of things. You really have to be able to block off to finish something, the big things, because all these other things, they're small.
Health equity is incredibly important, and health equity applies to research. We still need to make sure that our research population is representative of the population of patients that we see. We don't see very many women doing research. We don't see many different ethnic groups being part of research, and these are key lesions we still need to fix.
I think 2020 has also taught us if we can't look after our community, we're not doing good medicine and we're not safe ourselves. So I want to see, along with innovation and linked data and big data, I think some of the most exciting things are old school principles of collectivism and teamwork and making the decision to do what is right for everyone rather than what is best for you.
More equity wouldn't seem to be too much to ask for. I don't think it's an easy world for the younger generations. They are faced with a world that is more complex than it was when I was young, but they're extremely confident and they have a lot more confidence in any case than I did at their age. And I think that's great to see because they're going to need it.
The next generation leader really has to bridge the old school and new school, I think. That person has to be savvy with social media and understand that generation, but also understand the older, more conservative, perhaps, crowd who don't work the same way, a lot of time don't think the same way.
A next generation leader is humble, creative, and curious.
Someone who can collaborate effectively.
Less ego and less politics is essential.
A next generation leader is passionate about understanding their specialty, is inclusive in who they treat and who they include in the work that they do, and who, as a result of all of that, is inspiring. No matter how old or young we are, we still look for heroes and we want to be inspired.
I just want to start off by thanking Women as One for organizing such an incredible series. I've personally enjoyed the previous talks, and I also want to express how much of an honor it is to participate in such an esteemed panel. But before we start, I just want to recognize and really appreciate what we're doing right now. In this moment, the five of us are together, but we're from different places. Dr. Harrington, and I hope I get all this right, but Dr. Harrington's in California, Dr. Burgess is in Australia, Dr. Wong, you're in North Carolina, Ali, I believe from your area code, you called me earlier today, you're in New York, and I'm here in Ohio. The way, and this platform is being enjoyed by an international audience. The ways in which we disseminate information, the ways in which we connect is changing. And it was already changing before, but COVID-19, the pandemic, certainly jump-started this. So I want to ask all of you, and Dr. Burgess, in the video, you started off talking about how people are connected. So maybe I'll ask you first, but how do you see this evolving into the future? How will we share and consume information down the road? What will scientific sessions and meetings look like down the road? And how do we balance this incredible fruit of access to information with information overload? And Dr. Burgess, I believe you're muted.
I'm very sorry. I wish the question was, how do we supervise a registrar clinic while doing an international podcast? Because I've just failed that. But if you could just summarize the question really briefly, I'm certain I can answer it.
Yeah, so the way in which we are connecting with one another and sharing information is changing through webinars, through scientific sessions that are available online for everyone. How do you see that evolving into the future beyond COVID era?
I think we'll take all of the unexpected advantages of the COVID era, and we'll also be so grateful for what we took for granted. So I'm a doctor in Australia. I'm really lucky, and I'm counting my blessings. I wear a mask just in case we have coronavirus around, but I think we're on our 4th day of no community transmissions in Australia. I come from New Zealand, where there are no community transmissions and haven't been for a long time. So we're lucky to be isolated, but we really felt that isolation in terms of what we couldn't share with our colleagues. And I'm so grateful for all the conferences I've been at, and I remember how strong those conferences made me feel academically and also in networking. There are 17 women who are interventional cardiologists in Australia. We're spread across a really big country. So I'm really grieving for what we've lost in terms of networking. When we can network again, I think we'll have to be a bit safer initially, but I think we'll be so grateful for all of the time that we took for granted with each other and all of the opportunities. But we'll also have real skills in Zooming and working through 24-hour periods of time together, and appreciating that we have shared experiences, even if they're geographically isolated, and they bring us together in a way that we might have forgotten if it hadn't been for this revolting year.
Thank you, Dr. Burgess. Yeah, I think there's certainly a balance here. We are in some ways more connected, but in many ways more distant. The personal touch, the ability to shake hands and network maybe took a little hit for some time, but Dr. Wong, what are your thoughts about how we will connect, network, and share information down the road?
Yeah, that's, yesterday I was in a 6-hour meeting with a group of folks on video on something like Zoom. And the thought occurred to me, as cardiologists who've trained and risen to where we are, we're all multitaskers. Now, in the old days, when you had a group of people sitting in a room talking to each other, we had to patiently wait until whoever had finished talking before we can, come in and say what we wanted to say. But nowadays, we're talking to each other and we're chatting with each other on the Zoom at the same time. And so yesterday during this, meeting, it felt like we were having actually a still very high quality communication, but almost double or triple the volume of content that we sometimes get in the in-person meetings. And that's a plus of this whole virtual setup. And I think we're all learning how to do that well. Now, there are definitely downsides to this. But it occurred to me yesterday that, after leaving this meeting, I felt like, and we got the feedback from all the attendees, we really had a very full, very productive meeting, in part because there's the stuff we were talking about verbally, but also some of the things we were doing as a group that was in parallel with the conversation. I don't know, Bob, have you had this kind of feeling before? I mean, running think tanks or working groups, do you get that sense that somehow you're getting more out of these meetings?
Yeah, the example that I give is our medical grand rounds, which are probably like medical grand rounds everywhere, where we used to, invite these speakers in from various places around the globe, and they would talk for 50 minutes, maybe answer questions for 5 or 10, and then go on their way. And maybe we had 150 people in the room. Now we, at the height of COVID, we had almost 3,000 people joining our grand rounds via Zoom. This morning we had almost 500 people still joining our grand rounds, and it's taken on a whole new format. We invite every week people from our institution who give local updates, occupational health, what's going on at Stanford Healthcare, what's going on in the community, what are some of the infection control issues that people are seeing, what's our CMO sending out as messages. They talk very briefly, but then they answer questions while grand rounds is going on. So you've got a presenter, people are answering questions. And in an average grand rounds, we're entertaining 30 to 50 questions. That never happened, right? Mm-hmm. So to your point, Tracy, I think that there is an engagement that that we're not going to want to lose. The other thing that my financial administrator points out to me is that not having to rent the room and buy food from Stanford, we're saving over $100,000 a year. And I said, well, that's a good thing too, that we're not having like bad bagels for $100,000 a year. So that's.
Wait, I thought you guys were Uber eating, like sending food to faculty and attendees at their homes. I mean, something.
We are doing some of that. We're doing some of that with people. When residents do things, we send DoorDash to their house and things like that. Yeah.
That's incredible. I'm going to have to get a link to the Stanford Grand Rounds. But
it's been fantastic. We had, like this morning, it was somebody from the NBA who talked about creating the NBA bubble and how did they do it. And and the stuff that they have learned about viral transmission is extraordinary by testing people in a very isolated way every day for 3 months. I mean, really extraordinary. And they're sharing it. And that's how we got them to come. We have 2 of our faculty members, one Tracy knows well, Kevin Schulman, another one of our ID people, Dean Winslow. They've been part of working with the NBA on the research issues.
Now, Dr. Harrington, on the topic of flow of information, I'd like to ask you, how do you think scientific meetings will organize in the future? We went from most of the information being disseminated almost entirely in person to almost entirely virtual. But what do you think the future AHA meeting will look like post-COVID?
Well, we have scientific sessions for the AHA this weekend. And so it's going to be the first big scientific sessions for us. We've had some of our smaller meetings, including QCore that Tracy is intimately involved with virtually. We've had our basic science meetings virtually, BCVS, and now we're going to have our big meeting. I think that the meetings are going to be a hybrid going forward. What I've said to people is, I don't miss airplanes. I don't miss hotel rooms, but I really miss getting away. Mm-hmm. And because I miss the hallway conversation. Hey, did you just see that late breaker? I miss bumping into people. Hey, I haven't seen you in a long time. What are you working on? So that human piece that Sonia described, I think so well, I really miss that. This morning when I woke up, for some reason on my iPad, my old calendar popped up and it said travel to Dallas. And I was like, oh, I was supposed to go to Dallas today for AHA. And it made me really miss it because, I'm going to be sitting here in my office or sitting at home watching the event. But I do think it will be a hybrid. I think there'll be some of us who come, and maybe that's certain sessions, maybe that's certain groups of people. And a lot of us will go home. I mean, for those of you, ESC this summer was remarkable. There was like 100,000 people attended. And that's great. The more people, the better. But we got to have some of the personal stuff.
Yeah, and what you're talking about goes back to what Dr. Bridges was saying in terms of the personal connection and the networking. The way we share information was one aspect that was touched by COVID, but really the COVID pandemic posed so many incredible challenges at every level. Whether you talk about care delivery, virtual visits, how to keep your health workers safe, how to keep your learners safe, medical education, especially in the face of decreasing volumes of procedures and patient care. But it's been remarkable to see how all of the stakeholders came together to innovate and answer these challenges with solutions. So much of what we do now is different because of those solutions. And I wonder, what are some of the things that you think are here to stay? And what are some of the things that we may go back to business as usual? Dr. Wong, maybe I can ask you to start with this one.
Yeah, I think when I'm doing clinic visits now, I'm actually relying on patients to tell me about things that with these telehealth visits, I'm relying on them to tell me things that I can't measure myself. So blood pressure monitoring, for example, or weight monitoring for my heart failure patients. These are things where we used to bring them in, do the thing, set them in a room for a while, do it again because their blood pressure would be getting higher or lower. So I think that telehealth aspect of things is important because we've got patients who have barriers to coming in to visit. And in some ways, I'm sometimes seeing my patients a little bit more consistently now than I did before, because there's really no excuse for them not to do their visit. But it's also, in a way, educating our patients and engaging our patients in their health a little bit more. If they know that they need to bring their blood pressure measurements to me, and come prepared to that, they already kind of have a better sense of what they need to do with their blood pressure. And in a way, it's making, our interactions that much more effective. So that part, I think we really need to hang on to that. But there are parts of, I do miss seeing my patients. And I've, before COVID started worsening, I was starting to interdigitate some of these telehealth visits with in-person visits. And we're starting to revisit that. But I think there are definitely some aspects of this that are, impart the interaction and impart the engagement piece of things that I think will be here to stay.
Yeah, I think the advent of increasing access to care, just a basic visit where maybe you don't need to do a physical exam, something that I've definitely enjoyed having with my patients. But Dr. Burgess, what's your perspective on this?
Well, what I've loved about 2020 is the innovation we found because we had to. I mean, there's something about having no choice except finding a way that really does make us innovate in a way we can really be proud of. And I want to keep all of that. I love it when my elderly patients feel safe and feel looked after because I've called them in their home, and the thank you get at the end is it's just so nice. But I'm also aware that we can probably skip one in-person meeting or two in-person meetings, but we went to telehealth in February, and I've started seeing some people in person. In fact, most of them are people in person now, and I'm really feeling relieved that I can see them in person, because I think we are going to have a little rebound of problems that we just couldn't see because we weren't there doing those exams that were unnecessary for 9 out of 10 of our patients, but crucial for that 10th patient. So I think it's finding a new balance, and the trick is to pull out all of the things that are fantastic. Like my patients can go and find their medicines and see what they're taking. God, I love that. Rather than hearing it's that little blue one. That's fantastic. But I think there will be a rebound, and we'll need to find our way through that as well.
We can't talk virtually yet.
Maybe with a robot, but you still need somebody on the ground, right? But so yeah, Dr. Burgess, what you bring up is the need for balance, right? We can't be 100% virtual, but maybe we can also let some of it be virtual. Dr. Harrington, what COVID solutions do we need to hang on to, and what can we maybe let go of?
Well, I'll build not just the telehealth, but the whole concept of digital-based medicine. I now that I send people home with blood pressure cuffs and ask them to send me, a month's worth of readings. Why did I ever change somebody's blood pressure medicine on the basis of a blood pressure in the office once? Mm-hmm. I think about that now and say, what? This is a continuous variable that I measured once, and I just changed a medication on. That just seems crazy in retrospect. And now that you have access to all this information, I'll give you two anecdotes here of things that outside of cardiology that I've found fascinating. One is our orthopedic surgeons. You'd think, how are orthopedic surgeons using video? Well, it turns out that after you have an operation and you have stitches and sutures, the PAs and the NPs made a series of videos about how to remove your own sutures and staples by yourself at home. And then they would call people, show them the wound, They'd watch the videos, or their families watched it, and then they walked them through taking out their sutures and staples. And so people aren't coming from 2-3 hours away for a 5-minute visit. And it's been a huge satisfier to think, why did we ever do that? I've had surgeons say to me, why would somebody ever come back for a post-op visit? I can do the same thing, press down on that thing. Is any stuff coming out of it? It looks okay. And then the other one that's maybe a little more serious is our pediatricians who do family behavioral medicine say they're always going to do their first visit video because they can see the child in the home setting. And you go, oh, that makes so much sense. And things come up that they might not have been told. And I think that there's so many opportunities like this that why would we do it any other way? So we're going through an exercise now in our entire faculty practice where we're asking every service line to look by diagnosis. What should the optimal visit be in person versus the optimal use of digital technologies? And to Sonia's point, how do you identify the one that really needs to come back while making most of them just, be at home? And our primary care doctors, for example, are like, you mean I can do visits once my spouse gets home from 6 to 8 and they can watch the kids? What a great liberator that is. Or, oh, I want to do something on Friday with my family. I'll do clinic Saturday morning because I don't need anything other than a computer. So I think there's a lot of things that are great for the clinicians, that are great for patients, that are great for the system, that I don't want to see us lose.
Yeah, that's fantastic, Dr. Harrington. Of course, there is a benefit to be gained by laying our hands on patients, but clearly there's also such a benefit to not only improving access, but seeing them in their own element. And, going back to Dr. Wong's point about digital health, my day a couple of days ago, I went to Best Buy to buy a baby monitor. And as a podcaster, I got stuck in the audiovisual area. And so between the microphones and the cell phone cases was an entire rack of wearable devices, right? And everything from the Arm-on blood pressure device to, it was a cute little thing you wrap around a baby's foot and it measures the heart rate and the oxygenation and all those things. And I was just marveling, like, wow, like this is happening. It's here, right? I mean, digital health is a multi-billion-dollar industry. The industry is moving on this. The consumers and really our patients are adapting to this. But in many ways, we have to catch up, as policymakers, as insurance providers, even the way in which we assimilate data and effectively turn it back around to impact care. So, Dr. Wong, I'd like to ask you, what are the challenges in using wearable device? How do we effectively use digital health data to impact care and outcomes?
Well, I think there are several challenges we do need to deal with. First of all, there's still a very select subgroup of people who are taking on digital health devices. So in order for it to really exert its power, so to speak, there's got to be broader appeal and broader use. Now, I'm always psyched when my 70 or 80-year-old person comes in with their whatever. It makes me really, really happy that evolution is occurring. But right now, it's still pretty select. And I think we all know this. There's a bit of a healthy adherer effect. Often the folks who are wearing it aren't necessarily the ones who need to use it. So I think that's certainly one of the things. Second, that's sort of a pet peeve of mine is, this is great. I'm getting a lot of data from my patients, but I have no way of capturing that data in a way that I can effectively use the data. So for example, I will look at someone's Apple Health type of data folder and say, that looks great, or I'm going to make a little tweak. But I have no way of I have some way, but it's not easy, of taking that information and moving it into the patient's chart so that other people can see it, or I can remind myself about it the next time. So that, I think, is still something we somehow need to make these data streams, and it shouldn't be that difficult to do, right? So that this becomes data that is clinically useful, trackable, and then researchable, because that would be great, because I think we're really doing a digital phenotype of the patient, and as people are connecting more and more devices in, I think we're starting to really get a complete picture here. And then the final piece is that I think is still worrisome is the quality aspect of this. So how do we know that the data are really dependable? And how do we know that we're effectively using the data? And I think more and more research is coming out on this. Data is only good if it's great data. if it's crappy data, and we're changing our decisions in response, our clinical decisions in response to crappy data, we're not necessarily doing people any favors here. So I think those are some of the, the pros and cons of the digital health evolution, if you will.
Thank you, Dr. Wong. Yeah, it's certainly, it's sort of an onerous task, right? Like, how do you take all of this disparate pieces of data, it's almost volume overload, and turn that around to impact an outcome, right? And so, Dr. Harrington, what are the promises of digital health, and how do we address the challenges? Stanford's been very active in this area.
Well, I think that Tracy's raising important points. I mean, there's the quality data, there's what you do with it, how are the analytics applied to it, where do you store it, who's responsible for it. I think there's just enormous opportunities, and there's companies that are forming around these questions to try to help us, to try to disrupt it. I think that what's going to happen is that there's going to be systems set up where all of the feeds that Tracy's talking about are going to come into a central way, and then because the cloud allows that, right? It's almost like no data is too much. In the old days, there was an amount of data that was too much. The system couldn't handle it, but now the system has almost endless capabilities to handle even complex, disparate sorts of data, as you call it. And then we're going to apply advanced computational methods, AI, machine learning, deep learning, whatever, neural networks, whatever you want to talk about. There's going to be ways of the data being analyzed. Like, why would the four of us have to be looking at most of this stuff? The machine can probably handle a lot of it. And so let's do that. Let's figure out ways that with chat bots, et cetera, we can interact with our patients around their blood pressure, their glucose, their lipids, their weights, their heart failure management. Now, all of that has to be studied to answer Tracy's comment that, is this a reasonable way to do things? So I could imagine really interesting trials where there's a strategy of digital technology versus a strategy of, Marcus Welby doctor, to try to figure out which is better. I'm going to put my money on the machine as being better for consistently improving outcomes. It doesn't mean I don't think that humans should do it, but I think that the machine is going to be more reliable in doing it over time. And then we can figure out what's the best role that physicians and other clinicians can play. I doubt it's a lot of the things that we do now. One of our radiologists here who runs our artificial intelligence and medical imaging center, Kurt Langlotz, he likes to say when asked, will AI replace radiologists? He says no, but radiologists who use AI will replace radiologists who don't. And I think you could say that more broadly, that clinicians who use AI will replace clinicians who don't.
That's a great segue to a related question. And embarrassingly, when I hear AI, I think the Terminator. And I think that's not what you're talking about, Dr. Harrington. So, Dr. Burgess, I'd like to ask you, where does AI meet big data, whether that data is coming from wearable technologies or elsewhere? How do we use AI, machine learning, to harness data to affect outcomes? And I think you're muted.
So I think it's a great question.
By the way, when I started this, I told my wife, I was like, if I can make it through this webinar without talking about muted, I'd be very happy.
Okay. So you've just lost your bet with your wife, is that correct? So I think it goes to what Bob just said. We need to use all of our advantages, but we need to acknowledge that if we're not synthesizing it well and we're taking it at face level without understanding how we get the data, there is a real risk that we're not understanding the assumptions made. All AI, as I understand it, makes assumptions, and those assumptions need to be led by clinicians that understand the pros and cons of those assumptions. It's like reading a paper. If you read the summary, the Reader's Digest version in the email that gets sent to you without going back and looking at the methods section, you can't apply that data well to your patient because you don't know who they included, you don't know who they didn't include, you don't know what things they had to do to get it to this point. And like all data, we need to understand the details. So I think that the perfect marriage is a great clinician who wants to embrace new technology with new technology. But I would put my money initially on the physician and much later on AI, because if you look at our ECG reading algorithms, when they first happened, all of us said, that's the man in the box, you have to ignore him, he never gets it right. I've now started asking the man in the box what he thinks and taking him seriously. I think our algorithms are really great there, but it takes time to get there, and it takes fantastic physicians who understand what's going wrong to adjust it and make it meaningful for us.
Thank you, Dr. Burgess. And Dr. Wong, I get the sense that you love data. So I'm going to pose a question from Janine John, and for the audience, what's that?
Who doesn't?
For the audience, if you have questions for the panel, please submit them using the Q&A feature. But Janine John asks, how familiar do you think cardiologists should become with how AI works? And how do you anticipate clinicians will gain AI literacy in the future? And I'll add, again, like how do we operationalize this to go back to the price? How do we impact outcomes?
Yeah, I will confess that I don't have very much AI literacy. I love data, but I'm going to echo a point that Sonia made, which is it's all about assumptions. So whenever I'm seeing, listening to presentations on machine learning and these really cool things that are going on in the AI world, I'm listening very carefully to all the assumptions that they're making as they're analyzing. And usually, a lot of the early stuff has been about validation. So how do you validate an algorithm against what we see clinically? So I'm still in my head really going old school with, things like what kind of patients are they looking at? Is it too selected? Is it generalizable? I mean, these are, the principles that we're all very familiar with. How narrow or how wide are these assumptions, and are these reasonable, or do they apply to the types of patients we expect them to for this algorithm? And yeah, there's a lot of other stuff in there that, quite frankly, I might not understand, but knowing the assumptions at least gives me a gut sense of how much I'm going to be able to accept what gets spit out on the back end from this algorithm. Because if I don't agree with those assumptions, it doesn't matter what the machine did. At the end of the day, I'm still going to query what's going on there. And I think one of the key things for us as clinicians is really to just get repeated exposure to this type of stuff, because we've got this sort of spidey sense that helps us clinically diagnose patients and treat and make decisions in patient care and research and in other decisions that we make. And my sense with a lot of AI is sometimes there's really, we've got to sort of apply that spidey sense here as well. Some certainly objectively, but also some of the subjective perceptions here. But I will say that this is someone who does not do any sort of AI type of research. I'm just digesting this information. And hearing a lot of this, and I think this is an area that's going to grow a lot. And I would say, don't be afraid of it. Get a lot more exposure. I don't know if Bob or Sonia or you, Amit, want to suggest sort of ways to really learn a little bit more about the nuts and bolts here.
Yeah, Dr. Harrington, did you have something to add?
Well, I'm often asked about this, about, what do clinicians need to know about these things, or particularly for medical students, residents, fellows, people who are in the midst of their training. And there's just a great comment that comes up in the chat where somebody says physicians often get intimidated by AI algorithms, but applying epidemiology principles is probably the most important part. I agree with that. I tell people, they say, well, should I go like take a course in AI? I say, no, what you ought to do is make sure you're well grounded in basic statistical principles. Make sure that you're well grounded in basic study design issues. Make sure you're well grounded in understanding sort of basic principles of informatics and data management, because all the things that Tracy and Sonia are bringing out are the basic principles. The basic principles haven't gone away. And do you need to understand how to do really advanced computation? Maybe, if that's what you want to do, but if I went around the four of us here, do any of you actually know how they do a CBC? Do any of you actually know how they do, a chemistry panel? No, you trust that it goes into this machine and it spits out an answer that you've trusted. And so I think we've got to, don't be frightened of this stuff. It's just another tool. But you have to understand how things were created. There's a saying, all models are wrong, some are useful. And I think that applies to algorithms as well. And don't be intimidated by it, but learn the basic principles. And Tracy knows this because we come out of the same research group, which is that training clinicians in basic quantitative methods is probably the most underutilized but most important thing we can do. I have no idea why we teach medical students much of what we teach them. It seems to me to be a waste of time. But some of the things that we don't teach them are the things that they need to be learning. And a lot of that is mathematics, statistics, informatics. I mean, probability is a much more important concept than the Krebs cycle.
That's so funny, Dr. Harrington, when you said, I don't know why we teach so many of the things that we do, the Krebs cycle was the first thing that popped into my mind.
I get in trouble all the time for saying that. I live on a campus where biochemistry, Nobel laureates really important. I'm not diminishing the importance of the Krebs cycle, but I can look it up if I need to figure it out. But when I'm taking care of patients, I better have a basic understanding of what is pretest probability. How do I understand sensitivity? What does it mean when they say this test is not really specific? I mean, those are really important concepts that all of us use every day, but most or many clinicians don't really understand what those mean. COVID's helped with that. Right? Because everybody talks about true positives, false negatives, all that stuff now. That
on mainstream media. Yeah. I'd like to shift from statistical principles to ethical principles. And we think that the core principles of ethics are autonomy, beneficence, non-maleficence, and justice. And I think we, for the most part, get a lot of that right. But if COVID-19's taught us something, it's that there is something fundamentally wrong with justice. It's disproportionately affected communities of color in a way that just can't be explained by physiology alone. And when I, hear much of this conversation, we're talking about virtual health visits or digital health and wearable device technologies and big data. I think, are there ways that we can use this information, use these technologies to improve healthcare disparities? And this sounds like such a big issue, but as individuals, as people on the ground taking care of patients, what role, Dr. Burgess, we can start with you. What role can we play in bridging the gap?
I think this is such an important question, and it's a question I've been an outsider on because I was trained in New Zealand. I'm a first generation university attendee in my family. All my brothers and sisters went to university, but my parents both didn't really finish high school, although my dad went back to do some training later. So I understand, I don't think it's them when I think about poor people. I think I'm a generation away from it. And I know the stories my mother told me about not having food and worrying, but they never didn't have healthcare because New Zealand has free healthcare for everyone. No one takes their wallet out. No one thinks if I get sick, how much will it cost me? And I did not have any idea what a luxury that was till I started watching healthcare in America, and I just didn't understand it. And I don't understand how hard the pressures on you guys must be when your first questions have to be, what is your insurance? Because I so infrequently ever have to ask that question. And I think if there was ever an illness the world has seen that taught us we need public healthcare systems everywhere, it's COVID-19, because the rich got penalized and the poor got penalized because our lives all changed. But the people that died were the people that didn't have healthcare. And I think we need to say, I don't care about AI. I don't care about anything except serving people well for them and for me and for the sort of world I want to live in. And I loved hearing you talk about autonomy, beneficence, non-maleficence, and justice. I think that is incredibly important. But if we're not looking after everyone, are we really looking after anyone at all?
Yeah, I love the way you talk about different healthcare systems and what we prioritize, as a society. But Dr. Wong, what are your thoughts on how we can, in the next generation, with the tools and technologies available to us, help bridge the gap?
I'm going to say that it's really not about the coolness factor or the sort of the novelty of these. I think fundamentally, from a health disparity standpoint, there are two age-old problems that we just have not touched on yet. We've not been able to fix these problems: access and adherence. These are not new problems. They've been around for decades, and we've made so little progress on these. So to the extent where digital solutions might move the needle on these two things, I think we could do so much more to reduce disparities. And it's not the treatment aspect of it. I think we need to focus on the prevention aspect of things. I think that's really how we're, sorry to all three interventionalists, you guys are all treatment people, but I think we got to go further back. I mean, we got to get people access to healthcare. We got to get them focused on prevention, and we got to get people adherent to a healthy lifestyle and to the things that they need in order to stay healthy. And those are the ways that we can really fundamentally shift or reduce that gap, that the health disparities gap here. I think this has been a challenge. It's going to continue to be a challenge until we can really break down these big problems. These core problems.
I'd say that aborting a STEMI is a form of tertiary prevention, but I'd have to agree that where the money is the primordial prevention. So I think we're all on the same page.
As the only non-interventional person on this panel, I have to make fun of you at some point.
Dr. Harrington, on a related note, what's the link between healthcare disparities and professional diversity? Like, what does the face of the next generation need to look like to help us address the disparity gap?
Yes, I'm going to give a stepwise answer here because you're asking a really important question. And for part of this, I'm going to put on my American Heart Association hat because it was a topic I talked about a lot during my year as the AHA president. First off, groups like the AHA and others have talked a lot about the social determinants of health for a long time. It's been said that zip code is a more important determinant of your health than your genetic code. And that's true in America. It's true some other places of the world, but maybe not as starkly as it is, as Sonia has pointed out, in the United States because of our healthcare system. The second that I would point out, and an important part of AHA this coming weekend, we issued a paper yesterday, presidential advisory, that comes under Mitch Elkins' signature with a great group of co-authors that's called Structural Racism as a Public Health Problem. And we are calling out, ourselves included, as cardiovascular leaders, about the problems in healthcare that really have to do with structural racism that in this country go back several hundred years, and things that the AHA needs to do from a social justice perspective to begin to think about how to address this in our advocacy, in our science, and this gets to your workforce question, and in the people who are doing the science. And so there'll be a lot of discussions this weekend about what we might be able to do as a cardiovascular community to address the issue of structural racism leading to health disparities. Part of that is the opportunity gap, right? And that's what you're getting at. which is we know, for example, that that communities of color trust clinicians of color in a way that's not surprising. People want to see scientists and clinicians from their own background, from their own community. And there's a whole literature on trust that deals with these issues. And I think we, as a cardiovascular community, have to address this. Certainly, Tracy knows I've been on the call for more women, for example, in cardiology for several years now, because I've recognized that my generation did not pay attention to this. And consequently, we have a cardiovascular community that's 15 to 20% women in the United States. Well, how many of our patients are women? Let's roughly say half. So we are not doing a service to our women patients. We're not doing a service to our women trainees. We're not doing a service to society at large. So there's so much of this that we have to do. And I think that the one thing my generation can do, since we didn't address it, is that now that many of us are in positions of leadership, we need to address it. And so you'll see groups like the AHA, the ACC, the ESC really calling for change. And I think that that's going to be important. Our workforce should look like our population.
Mhm.
Yeah. Thank you, Dr. Harrington. And, you know, on the topic of raising awareness and advocacy, I'd like to just touch on the use of social media, you know, and the space of hashtag #MedTwitter or hashtag cardio Twitter has become such an incredible community, but when used properly and effectively, you know, but people use it for advocacy. You think about hashtag women in cardiology, or Dr. Capers hashtag Black men in medicine, or when Dr. Harrington so proudly writes hashtag he for she. You know, the cardio nerds, we use it to disseminate cardiovascular education, you know, and it's become such a powerful force. And I'd like to ask each of you, maybe starting with Dr. Wong, what is your personal relationship with social media? What is your advice for newcomers? And what cautions would you like to share?
Well, I was dragged kicking and screaming to Facebook. It was a lot easier to join Twitter. I will characterize myself as a casual tweeter. And my philosophy, and I actually just said this 2 days ago, everyone should try it. If nothing else, you can lurk and you'll learn so much information just by lurking and not posting. You don't have to post to be on social media. That's one key thing I learned. But there is such a wealth of information that you just don't get through traditional channels. You know, I heard that the interventional community is particular, like people are learning how to cath by Twitter, I heard. No, seriously, I see all these polls about what do you think about this? How would you approach this? And I mean, it's really a community building thing. But what I would say to people is, don't be afraid of it. If you've never done it, try it. Even an old geezer like me can do it. You either love it and embrace it and go all in, or you could be a casual social media presence like mine. Or you could just lurk there and still learn a lot of information, or you could hate it and you could get off of it. It's not a marriage. There's no formal divorce at the end of this. So go for it. Give it a try.
Give it a try. I think those words you can use for most experiences. I love that. Dr. Burgess, what is your relationship with social media and what advice do you have?
I have a beautiful relationship with social media. I was a skeptic. There was no way I was going to tweet. And here are some reasons. I spell terribly, especially when I'm multitasking. All of my family are appalling at expressing their opinions and then thinking about it later. Twitter was never going to be a place for me, I thought. And then I had a really important paper. That paper was really important to me. It was published in JACC. It was the paper that made me feel like maybe I could do something amazing in my medical career and I had infinite potential. And JACC said, what's your Twitter handle? I don't know how to tweet. I didn't know what to do. I had to Google how to tweet. And I was scared of getting it wrong. And my co-author had already started tweeting, and I felt like I had to contribute to get this paper out. As it happened, it got into the 99th centile of shared papers. It got an altmetric score of something like 212 or 213. People meet me at conferences pre-COVID and say, who are you? And I'll tell them my name, and they will say, oh yeah, I know who you are. Now, that is extraordinary, because honestly, if I'm being humble, I am no one. I am no one, but I'm someone who wrote a paper and people read it, and social media and some great co-authors are the reason people read it. And then I went on to write a paper in circulation. I've got a little letter in JAMA Cardiology. I've written in a lot of the really big journals, and I've got my confidence because people have responded immediately and told me how that paper changed things for them. I've got a friend from the Mayo Clinic who said, you know what, when I'm getting my students to write papers, I pull out your paper and I tell them this is the way I want you to write it. That's amazing. And I wouldn't have that at all if it weren't for the fact that someone said, give it a try. And I thought, I need to do this. I get to see what my heroes think about papers the minute they're published. How exciting is that? You can't throw away all of that just because you're a little dodgy in your spelling and you need to think twice before you express an idea. So what are my messages for anyone trying? Google how to tweet, look at the warnings, look at what you can do to protect yourself. Think of Twitter as what you would say on a conference panel. If you wouldn't say it on a conference panel, don't say it on Twitter. And try and be positive. I think you can frame anything positively, and Twitter loves positivity, and we can make a change by including people and sharing our ideas on social media in a way that I just couldn't have imagined until I started.
Thank you,
Dr. Sonia Burgess.
Thank you, Dr. Burgess. There is it's not a steep learning curve, but it took me a while to figure out what the difference is between leaving a comment and doing a retweet with a comment. But I think I've got the handle, and your story is so compelling and inspirational. I can relate in a much smaller way in the reception that people get from the content we make on CardioNerds, but it really is just such an incredible way to connect with people. Dr. Harrington, what's your perspective on the force of social media, and how do you engage with it?
So first off, I've loved hearing Sonia's stories. Those are really fantastic. I have, during much of my career, have felt that using different modes of communication is really important if you want to get your message out there. I do believe that having a base foundation of good work, which is what Sonia's describing, is really what you want to have first before you're communicating about it and starting with. So you got to start with credible information. And I've been on Twitter for a long time, I think more than 10 years now. And I've had a podcast for more than 10 years now. And I like the different venues that they offer me to communicate ideas. I started my Twitter account as a way to engage in more conversations around medical meetings. And so if I go back to the early tweets I sent out, it was always, nothing, ACC, whoa, nothing, ESC, whoa. And that's how it was. But I really enjoyed, communicating my ideas of a meeting. And then over the years, that's changed to where I'm a much more regular contributor to Twitter. I use it for a variety of reasons. I use it to keep up with the literature. I follow all the major journals that way. I follow a number of people who I believe have good taste in science, that I want to read what they're reading, including people who aren't in my field, but I follow them because they have interesting things to say. I like debating people, and getting out there with that sort of discussion. And so that's what I use Twitter for. I follow the literature, I engage in conversations. I do, as Sonia does, I promote things that either our group has written or that I'm particularly interested in. I promote a lot of AHA stuff that way, and that part's been really fun for me to use it. On my podcast, I use the opportunity to just have a conversation with a guest who seems to be doing something interesting that might be worthwhile for the cardiovascular community to hear. And I like that. My piece of advice is decide what you want your persona to be. And if you want to be a cardiologist on Twitter, be a cardiologist. Don't be a politician. Doesn't mean that politics and healthcare can't intersect, but don't be all over the place, because people want to follow you for a reason. They want, I have the people I follow because I'm interested in sports. I have the people I follow because I'm interested in cardiology. I have others because I'm interested in health policy. But decide what your contribution is going to be. I largely just talk about heart stuff. Since Sonia threw out her Twitter handle, I'll throw out mine. You can follow me at @HeartBobH.
Thank you, Dr. Harrington. Talk about being an early adopter of technology. We're a little over time, but I think very briefly, I'd like to end with a final question for each of you. And just pretend you're talking to a room full of young trainees who are embarking on the rest of their career. What are the characteristics, what are the traits that make the next generation leader? Dr. Wang, perhaps we could start with you.
I'd say be open-minded, be open to new things, because the field doesn't stay the same. I think the field continues to expand. So be open to new partnerships and new opportunities, and be humble.
Terrific. Dr. Bridges?
Still on mute.
I think believing in yourself is extraordinarily important. And I think you should find someone who believes in you for those days that you can't quite believe in yourself as much as you should. I think always be learning and question assumptions, and kindness in medicine, kindness in the politics of medicine. There was a question here we didn't get to about the politics of medicine. There's never a time when I've regretted being kind or inclusive in everything I do. And if you believe in yourself and you keep working hard, I think there's no limit to what any of us can do or who we can lead. And I also like to ask, if I'm going someplace, who can I take with me? Because I think including people who might not otherwise have been included is a really important way to make our profession more diverse.
Dr. Harrington?
Yeah, much of the great advice has already been given. I'll stress if you're a young person training, make sure you get great training, get great clinical training, get great research training, whatever it is that interests you. But you're only going to get that training as a young person. It's hard to get it later once you've joined a faculty or once you're in practice. So get as much training as you can. Find a mentorship team that can help guide you. I think that the advice around having people who will help you is really important. And then be curious. I always like to remind our fellows and our residents that even in cardiology, which is so guidelines driven, only about 15 to 20% of what we do is actually supported by a really high level of evidence. So there's a ton of questions left, and be curious and be collegial, be civil, be collaborative. One of the things I also tell people about social media, Clyde Yancey and I have done a few podcasts on this, is be civil. Be civil in public discourse. And sometimes that's lost. And I'm with Sonia all the way about being kind. I've found over the years of my own career that relationships that I've had now for decades, in part, are because you were kind to somebody, you helped them out, and that comes back to benefit both of you later on. So there's no, I like to say there's no place for meanness in the world. There's enough of it outside of what we all do that let's not try to bring that into the profession.
Thank you, everyone. That was a great roadmap for how to become a leader. Well, Dr. Burgess, Dr. Harrington, Dr. Wang, thank you so much for discussing these topics with us today. For Women as One, especially Ali for coordinating. Thank you for putting all of this together and organizing. And a very special thanks to our audience for letting us borrow some of your time.